All right. Okay, here they come.
Yahoo!
The popcorn is popping. Wow, welcome everybody. This is so great. Yeah, so I'm Dr. Ted Barnett, the high-tech doctor with low-tech solutions, president of Rochester Lifestyle Medicine Institute, and I'm so excited to bring you this panel tonight. Co-hosting is Dr. Robert Breakey from IHA. So, yeah, and of course our guest panelist is Dr. John McDougall. So welcome, Dr. McDougall.
Thank you. I'm real happy to be here.
It's so great to have you here. I know you're out there in Portland, Oregon. Dr. Melissa Sundermann will be presenting the case tonight. And Dr. Kim Scheuer is on the panel as well.
Nice to see you.
Yeah, and we're missing one of our panelists, but I think we'll be fine. Dr. Kerry Graff, also from Rochester. There she is. Well, that's good timing. You know how to keep us in suspense, Kerry. Yeah. Anyway, it's good to see you. So one of the things we like to do is find out where everybody is from, and because we have people from all over the planet joining us. So our engineer, Bob Frankie, is going to be putting up a poll. So you get to take a poll now, and we'd like you to check off your highest academic degree and where you're from, and make sure that you click something, even because there's several components to this poll. So I'm not allowed to come because I'm on the panel. Is that right, Bob? I thought I could.
No, I think
Oh yeah, I can. There we go.
Yep.
Right, there we go. Okay, it's letting me do it. And if you live outside of North America, you've got to click something there. Otherwise, you can't submit the poll. You have to answer something in every section. So if you I see live it. So then if you're not on one of these lists of specialists like specialties, then click other so you can go to the second part. And
Oh, I see.
looks like we got radiology in there twice. We got to fix that. It's a little prejudice. Because I'm a radiologist, so I figure everybody is. Okay, good. So go ahead and click submit when it says 6 of 6 answered, and then let us know if you're having any trouble. Speak up, because looks like we should be getting about 30 responses, Bob, maybe 28.
The total is 28, but if there are any RLMI people, they probably won't be responding.
Okay, good. So
We'll watch it like popcorn.
okay, yeah.
I don't know if you had any other announcements while we're doing that.
No. Oh, well, one thing I did want to tell people, the American College of Lifestyle Medicine annual conference ended last week, and it was just great. There were 2,400 people signed up from 25 different countries, and I'm hoping some of you were able to make it. Probably were. And of course, from our point of view, it was very exciting because we were able to announce certification of our 15-day whole food plant-based jumpstart by the American College of Lifestyle Medicine. So we had to jump through quite a few hoops to get there, including getting 2 articles published in peer-reviewed journals, which we were just so excited. So anyway, so now it's CHIP, LIFT, and our jumpstart, which we run all 3 of those in our organization, and really fun. And what other announcements did I want to make? Oh yeah, I'm supposed to tell you all to like us on Facebook. There, I said it. And Instagram or Twitter or whatever else it is. Okay, that was enough of that. Bob, Frankie, we got the poll here? There it is. All right, so we got 71% are doctors or DOs, PA, PhD, RN, a couple of chiropractors, and then 8% others. Looks like 46% are from the Northeast. And so Bob, are they seeing me scroll, or does everybody scroll their own? I guess everyone scrolls their own.
I think people can control their own scroll.
Right, because I don't think people are seeing what I'm doing, and I'm scrolling it. So we got one person from Mexico. I know about her. Welcome. And then it looks like pretty much everybody else is from the Midwest and West. One person from South America. Okay, primary specialties, 25% family medicine, 33% internal medicine, We have a cardiologist, a radiologist, an oncologist, OBGYN, and then 25% are other, which is psychiatry, and then again, other. So, and this is how we found out about it. Great. All right. So now that we got that, so we could kind of get to know each other and you guys got to practice taking polls. There will be 3 polls inside this case today. And Dr. Sundermann, why don't you start sharing your screen? She'll be presenting a really interesting case and letting us know when we should stop and discuss it. So with this august panel we've assembled. So.
Okay, can everyone see my screen?
I'm seeing it. Yep.
Okay, and you can hear me. So I'm Melissa Sundermann. I am internal medicine, lifestyle medicine from IHA, which we're located in the Ann Arbor, Michigan area. Go Blue. So here's my case, the title, And Then There Were None, How to Solve the Mystery of Prescribing. Let's see if I can get my, okay. So as we know, this is what we try to fight in lifestyle medicine. It's not that we don't prescribe medications, but we are really looking at alternative ways of improving lifestyles to hopefully prevent the flood of medications. So this is a case, 59-year-old Caucasian male. He originally presented to IHA, our group practice, on October 14th of 2014. At that time, he had an A1C of 9.9, fasting blood sugar of 268, cholesterol of 336, HDL of 51, triglycerides were 680, and the LDL could not even be calculated secondary to the high triglyceride level. Body mass index of 31.37 and a blood pressure of 148/88. His past medical history that was brought into this visit is that the chart said he had type 2 diabetes. He didn't know he had that, hyperlipidemia, non-obstructive coronary artery disease, gout, diverticulitis, and smoker. Social history, he's divorced. He has 2 adult children. He works as a software engineer and he's a smoker, half pack per day. At that time, he had a 15-pack year history and he has a dog. Family medical history that he could remember, both his mother and oldest brother had type 2 diabetes and his heart disease in his father. So this is our first poll, and knowing those labs that we saw before and having his history, and when he came in for this first visit, he was non-compliant before, he wasn't taking any medications. So, what are your recommendations for next steps? Should you start metformin 500 milligrams twice a day? Should you start metformin in a sulfonylurea, such as glipizide or one of the other ones? Should you counsel for lifestyle medicine pillars and then have them work on these pillars and then repeat labs in 3 months? Should you start a statin and metformin? Should you start an ACE inhibitor, statin and metformin? Or should you do everything above? So that's our first poll.
Let's run the poll. Great. And then we'll get hear what this panel has to say. All right. So that one shouldn't take too long. It's a single, right? Bob Frankie, we ready? There we go. There's the answer.
Let's see what we got.
Yeah.
Okay, so we obviously are a group of lifestyle medicine physicians here. So 50% of people said, let's, counsel for lifestyle medicine pillars and repeat labs in 3 months. We also had a lot of people who thought we should do everything. So starting a statin, metformin, an ACE, possibly a sulfonylurea. And then some people thought we should just do a statin, metformin, and a smaller percentage ACE, statin, metformin. Okay, so again, I'm going to say this is prior to me taking over his care. So let's see what this doctor did. So I was able to pull the chart, and the doctor who wrote this in the HPI said this patient was irritable at the beginning and the end of appointment. He said he couldn't exercise because he had pain in his feet and legs. So the provider, started the patient on metformin 500 twice a day, as well as glipizide 5 milligrams daily. and then Chantix starter pack for hopefully smoking cessation. He was told to stop consuming all candy and sugars because he was diabetic, and he was told to start exercising. And the doctor wrote, due to the patient seeming irritable, may need to refer to a nutritionist for an ADA diet. They did recommend some fruits, vegetables, and whole grains. So following that, on December 12th of 2016, he had an ER visit. He was complaining of palpitations, chest pain, shortness of breath. He was found to be in a flutter with RVR, a heart rate of 136. So he was originally started on a cardizem and heparin drip. He was transferred to a tertiary hospital, and he did have a TEE with successful ablation. So at that time, he was sent home on Xarelto for 1 month. His A1C drawn at the hospital had increased to 11.3. During his hospital stay, of course, they covered the blood sugars, and he was started on Lantus. However, since he hadn't been on Lantus as an outpatient, they discharged him on Metformin 500 milligrams twice a day and glipizide 5 milligrams per day. So he follows up on the next week with a TCM with his primary care physician. He states that he's working on cutting out pies and cupcakes because, previous doctors said you're diabetic and you can't have sweets. He states that he now plans to join a gym, and he's complaining of some loose stools the first few days of having his metformin. He actually was checking his blood sugars at home and ranging from glucose from 150 all the way up to 317. His body mass index still elevated at 30.93. Blood pressure a little bit better at 128/78. So the physician doing this TCM maintained the same medications, reconciled the meds from the hospital, continued glipizide 5 milligrams per day, metformin 500 milligrams twice a day, and Xarelto 20 milligrams per day. He was referred to diabetic teaching, and he was told by his primary care physician, again, because he's diabetic, that he needs to eat low carb, low calories, low cholesterol, low fat, and low salt. Now, I couldn't find anywhere in this chart any more explanation of what types of foods other than those descriptors. He was also referred to a sleep study. He was referred again for diabetic teaching. They recommended he had an eye exam and recommended daily exercise. So fast forward to April of 2018, this patient tends to be somewhat non-compliant, as we're used to patients like that. So he decided on his own to just stop the metformin and glipizide. He was checking his blood sugars at home, and according to him, he thought they were better. However, he was experiencing some polyuria, polydipsia, he was feeling run down, and he noticed some numbness in his feet. So in talking with the patient, the provider got him to admit that he's been consuming some cakes and donuts, but he's trying to do a good job and avoid potatoes and pastas. So I'm sure Dr. McDougall would disagree with that. He did not meet with a nutritionist, and I quote you from the chart, he had stated, "I've been a stubborn idiot asshole, but now I want to get healthy for my children and grandchildren." So at this visit, his A1C was 13.6, urine microalbumin 535, blood pressure 152/86, and a body mass index of 31.25. So BMI had gone up. Obviously, his A1C and microalbumin had gone up since he took himself off his medications, and blood pressure was elevated. So the provider said, these sugars are out of control. We're going to add more medication. He was started on Lantus 10 units nightly. He was also started on lisinopril 10 milligrams per day, told to continue the metformin 500 milligrams BID, as well as glipizide 5 milligrams per day. Again, he was referred to ophthalmology. He was obviously did not succeed with the Chantix, so they talked about tobacco cessation. And his dietary recommendations per the chart were advised to follow a diet low in carbs, low in calories, low cholesterol, low fat, and low salt. He was told to take these recommendations and then to get some repeat labs done. So about a month later, he states that he's been compliant. He's taking all of his medications. He's checking his blood sugars at home. They're still somewhat elevated, 199 to 302. He's feeling better though, and he actually read some books about nutrition. He's still smoking. He really didn't tolerate that Chantix because he had some nightmares. Body mass index, pretty much the same, 30.78. Blood pressure improved now at 118 over 68. He's on the lisinopril now. And lipid profile, cholesterol 388, triglycerides still very high at 896, HDL 42. And again, LDL was not calculated due to the elevated triglycerides. So this provider noticed that he's still having high elevated sugars and decided to increase the metformin to 1,000 milligrams in the morning, 500 milligrams in the evening. He increased Lantus to 15 units nightly. And then the patient was started on Wellbutrin for tobacco cessation since the Chantix had adverse side effects. And then told to continue the lisinopril 10 milligrams per day. Again, instructed to eat that same diet, nondescript, but low in carbs, calories, cholesterol, fat, and salt, but high in fiber. He was referred to a nutritionist once again, told to exercise 30 minutes per day, and referred to an eye doctor once again. 2 weeks later, patient is complaining of abdominal discomfort and diarrhea since increasing metformin. Sometimes it even wakes him up at night. He was, working at the gym and trying to eat healthier. So he states that he did lose about 7 pounds, and he actually scheduled to see a nutritionist in the upcoming week, and states he's feeling better. So blood sugars, little bit better, 157 to 226. Body mass index, about the same, maybe a little bit lower, 30.43, and blood pressure 102 over 62, which is improved. So because of the GI side effects, the physician felt that we should back down on the metformin. So went back down to 500 milligrams BID, told to continue the Lantus 15 units nightly, continue Wellbutrin 150 BID for smoking cessation, and continue lisinopril. So a couple months later, we have a new PCP. And this is still within the IHA system. And I think sometimes physicians change practices. So this is a brand new PCP. Patient is tolerating the metformin. He's not complaining of any loose stools. But the PCP says, he's still eating some carbs in the diet, such as bread and pasta. And blood sugars at home ranging from 180s to 250s. Body mass index slightly up, 31.19, blood pressure 148 over 82. And the point of care A1C in the office is 9.1. Again, this is decreased from his elevated 13. And the urine microalbumin is still quite elevated at 535. So looking at the numbers, the physician was still concerned that even though the A1C was improved, it was still too high. So just said to go back up on metformin to 1,000 milligrams twice a day. And then to consider adding lisinopril or consider increase the lisinopril dose at next visit. Blood pressure seemed, a little bit elevated, but was concerned about the proteinuria. And then again, chasing the blood sugars, was told to increase Lantus to 18 units nightly. In this recommendation with this new patient, there were no formal diet or exercise recommendations in the chart. So about a month later, fasting blood sugars in the morning are remaining over 200. He states that he is eating some fruits and vegetables, and he's really focusing on lean meats. So we've all heard that before. He was trying to cut back on his soda intake, and he was switching to diet soda that he would have intermittently. He does like his chips. He had some of those. However, he's been going to the gym. He's exercising about 5 times a week on the elliptical. Body mass index about the same, 31.76. Blood pressure improved at 118 over 78. So the provider said, those blood sugars are still elevated. Let's go up on your Lantus. So now we're up to 21 units at night. Also wanted to increase lisinopril to 20 milligrams per day due to the urine microalbumin. And then this physician looked at the lipid profile and said, I want you to start Crestor 5 milligrams per day. They were recommended to have a low sodium diet, under 2,400 milligrams per day. And they did recommend a DASH diet, including some low fat milk and milk products, foods rich in omega-3 fatty acids, which include salmon and herring and tuna, also olive oil and canola oil. Told to avoid sugar, sweets, and refined grains. Eat fruits and vegetables and whole grains, and you can have some beans and peas, lentils, and chickpeas. So I'm sure everyone is thinking right here, right? We're just what we would do differently probably. So a couple months later, another new PCP. I guess the patient elected to change because was dissatisfied with the timing and follow-up of the prior PCP office. At this time, he's really noticing that he's complaining of some mild foot numbness and he's got a cold feeling. He's not quite sure what's going on there. He's noticed that these symptoms tend to improve when he's eating healthy and exercising. Blood pressure 150/83, body mass index about the same at 31.22, and blood sugars ranging from 150 to 210. His repeat lipids, cholesterol 321, HDL 42, and triglyceride 770. Again, we can't get an LDL because of that elevated triglycerides. A1C, which was done in July, was 9.1, so still elevated. So this new physician said, I want you to get an Omron blood pressure cuff. I want you to monitor your blood pressure at home. Because the A1C was the last one that physician could see was 9.1 and the blood sugar still seemed to be elevated, told to go up to Lantus 22 units at bedtime. And if you need to, go up to 25 units because we want to get your blood sugars, less than 100 for fasting. Told to continue the Crestor 5 milligrams, told to continue lisinopril 20 milligrams, and still working on that smoking cessation. So continue the Wellbutrin 150 milligrams BID. Patient was referred to podiatrists for foot numbness, trying to figure out what's going on there. And then also, because it had been a couple of years, told to follow up with cardiology regarding his history of AFib, flutter with a history of ablation. And again, said to follow a low sodium diet, said to consume less than 2 grams per day, and then to exercise. So this was 8/20 of 2019. This is the same physician as he saw previously. He saw podiatry, and lo and behold, he was diagnosed with diabetic neuropathy. A patient had run out of a statin and decided, I'm just, I ran out of it. I'm not going to take it. And states that he did increase his Lantus to 26 units a night. He's feeling tired. He does admit he has snoring at night. He's not checking his blood pressures at home, and he admits he's due for his eye exam. So blood pressure 152/88, body mass index about the same at 31.71, and blood sugars ranging from 150s to 190s. So again, he's referred for an eye exam. A repeat A1C was ordered, told that he may have to increase the Lantus again if the A1C is too high. So they ordered a repeat urine microalbumin. Because he was feeling tired, the doctor said, we got to make sure that you don't have an anemia. So let's order a ferritin and a folate and a B12. He was told to restart his statin, and his lisinopril was increased to 30 milligrams per day since the blood pressure in his office was elevated. Told to continue the Lantus 26 units until they got the repeat A1C. He's recommended again and referred for a sleep study. And he was told to eat healthier and lower your caloric intake and increase physical activity. So a couple months later, he started going back to the gym. He states he's lost 5 pounds. He still is not checking his blood pressures at home, but feeling better. And he started taking vitamin D because he was told that was low. Blood pressure 143/84, body mass index 31. A1C is actually improved down to 7.2, and lipids look a little bit better. Cholesterol 296, triglycerides still elevated at 723, and HDL 41. So he's continuing his Lantus 26 units at night, as well as a Metformin, 1,000 milligrams twice a day. He's got a statin, Crestor 5 milligrams per day. He's now taking a vitamin D supplement. He's on his lisinopril 30 milligrams per day, and the primary care doctor said, okay, I think we'll just continue to do what you're doing. Get your repeat labs, and then go schedule your eye exam. So then COVID happens, and he doesn't see a doctor as due to lockdown. So he resurfaces once it's safe to come back to the offices about a year and a little bit over a year later on March 4th, 2021. And he states he's been walking his dog. He's lost some weight, still having pain in his feet. Blood sugars ranging from 150 to 200s. And he ran out of lisinopril a few weeks ago, forgot to call the doctor's office. His A1C in December of 2019, right before COVID, was down to 8.5, which was the best it had been. Blood pressure in the office on this visit was 164 over 86. He had run out of lisinopril, and body mass index 30.79, which is a little bit lower than the last body mass index. So physician said, oh, I think I'm pleased with the 8.5. Let's just continue on the Lantus 26 units, Metformin 1,000 milligrams BID. We're going to get some repeat labs, continue your statin, continue lisinopril, and that neuropathy, why don't you start some gabapentin, 100 milligrams 3 times a day. So a month later, still complaining of foot pain. We'll see on the right side. It was getting so severe, he thought that maybe he was going to need something stronger, like a narcotic. Pain is worse on some days, not as bad on others. He really wants to try more medication for foot pain. He's been feeling more depressed since recently retiring. Again, he's divorced, he's got grown children, but he feels like walking his dog helps with his mood and helps him to get some exercise. Blood pressure 130 over 65, BMI about the same at 30.43. A1C is back up though, went from 8.5 up to 11. Urine microalbumin is better at 46. Cholesterol coming down to 29, triglycerides 531. So because the A1C went up, physician said, let's go up on your Lantus. And now we're up to 30 units nightly. Continue the metformin, 1,000 milligrams twice a day. Because of blood pressure and microalbumin that the doctor could see, she thought we were a little bit too elevated, told to increase lisinopril to 40 milligrams per day. And then because of these cholesterol numbers, even though they're improved, they're still elevated. So increase your Crestor to 10 milligrams per day. And then really want you to continue the gabapentin, 100 milligrams 3 times a day for foot pain. And again, he was referred for an eye exam.
Did he ever go for the eye exam?
I don't know. I don't think so.
Okay.
So to bring you up to date, so this is now September 29th of this year, and this is the first visit with me. I came into a new office because the prior physician had moved out of state, and so I inherited a lot of this physician's patients. So first visit for me was in September. The blood sugars are usually running around 200 fasting. He states he's been working on cleaning up his diet, and he actually admitted that he was cutting down on consumption of meat. His feet still hurt, and gabapentin really wasn't working. And the foot pain was really starting to affect his mobility and ability to exercise. The good news is that he had quit smoking. Blood pressure was 158 over 77. BMI was the lowest it had been at 29.63. And his A1C, the last time he saw a prior doctor, in April was 11.0. So we spent, a good amount of time talking about, what a whole food plant-based diet was and how to transition. He was referred to the Mastering Diabetes website. We gave him book recommendations by Dr. John McDougall and Dr. Neil Barnard, Brenda Davis, and Dean Ornish. We talked about exercising at least 150 minutes per week at moderate intensity, and we kind of went through what moderate intensity, in layman's terms, what that felt like and what that meant. Again, he was referred for an eye exam. He was referred to Jumpstart program, Dr. Barnett's program, 15-day Jumpstart. And at that time, since I didn't have any lab work on him or anything like that, and he hadn't really adopted any of the lifestyle medicine recommendations yet, I didn't feel comfortable modifying medications yet. So he was continued on his regimen before he came to see me. Lantus 30, Metformin 1,000 BID, lisinopril 40, Crestor 10. He read someplace, he really wanted to try Lyrica. And so again, this is the first time I've met this guy. And so I said, if you really want to try it, we can, explain to him about neuropathy, how that's so tied to tight glucose control, but he really wanted to give it a try. So we gave him a prescription for Lyrica, 150 milligrams TID. So, and then I ordered repeat labs. Okay, so this is my note from labs that he got. They keep thinking I'm a neurologist. I don't know why, but and so we reviewed his labs as his MyChart message I sent him, and his A1C had gone from 11 down to 8.1. So I said we may be able to decrease your diabetic medications. His fasting glucose went from 233 down to 118, and his cholesterol decreased from 229 down to 157, and triglycerides went from 531 down to 248. So I said, great job. Please schedule an appointment so we can discuss next steps for possible decreasing of medication. So basically, this is our goal, right? The patients come to us with a handful of medications, and we really work hard to de-prescribe. So here's the next poll. What should be the next steps in de-prescribing? Do we want to, because we have that improved A1C and the improved cholesterol, do we feel like we want to lower the Lantus dose, to 20 units per day? Do we feel like we should lower the Metformin to 500 milligrams BID? Do we want to lower Crestor to 5 milligrams a day? Should we stop diabetic medications and focus on a whole food plant-based diet, exercise, and weight loss? Should we stop the Crestor and focus on a whole food diet, exercise, and weight loss?
And Bob, the answers are?
All right, so it looks like the most popular was to work on the Lantus first. And then some people said, well, actually equal split between stopping all diabetic medications and focus on lifestyle, and stopping the statin and focus on lifestyle. And then some people said to lower the metformin. So Ted, do you want to discuss the panel to figure out what they think should happen and just give
Sure.
some insight to what's going on? And then we'll see what I decided to do.
And just for the record, Dr. Graff put in none of the above in the chat because it wasn't the choice for that. So
Okay.
let's hear.
Well, then
let's
she
hear-
can share with what she wants to do.
Sure. Let's hear from Dr. McDougall. John, where would you start?
Well, I tell you, this must be very frustrating for you folks. This is what's called managing patients. I'm glad I don't practice this way anymore. In fact, I stopped practicing this way 44 years ago. I have the advantage of being able to put people in a residential situation so that I can control what they eat. And I can also change the medications that I would offer them on a daily basis. In other words, if the blood pressure went too high when I stopped all the blood pressure lowering medications, I could restart them on some medication. So again, it must be very frustrating to chase these drugs around and to chase the lab tests around. But what I would do if I had the advantage of taking care of the person in the practice that I've done for the last, 44 years is I would put them in a live-in situation. I'd walk them around a little bit, give them a little bit of sunshine, change their diet, and stop all their medication.
Mhm.
I mean, all of it. You'd give me that choice. I would stop it all. And I could tell you why. The diabetic medications, what you're doing, or what we would be doing, would be dealing with the problems that were brought out in 1986 in the New England Journal of Medicine with the Accord Advance and Veteran Studies. All three of these studies showed that aggressive treatment of diabetes with an effort to maintain a hemoglobin A1C of 6% resulted in an increased risk of death, heart disease, sudden death, weight gain of approximately 18 pounds. It makes no sense at all to treat a patient with a medication regime that makes them sick and causes them to die. So I would stop the medications if he was truly a type 2 diabetic. I mean, type 2 diabetics mean you don't need medication. Type 2 diabetics end up producing as much insulin and often twice as much insulin as somebody who does not have diabetes. Now, this person may be what I call a type 1.5 diabetic. In other words, they produce some insulin, but not a normal amount of insulin, so their sugars run a little high. They end up having frequent urination, and they lose a lot of weight. And they worry about the numbers too. And for that reason, I take patients who have type 1.5 diabetes. Remember, type 2 is curable, essentially 100% of the time. I would take somebody with partial insulin insufficiency and I would treat their symptoms. I'd put them on a little Lantus. I like Lantus. And I would stop the weight loss. I'd stop the polyuria. And I'd stop the mother-in-law from worrying about the numbers all the time. So that's the way I would handle the diabetes. And with weight loss, and if he's truly type 2 diabetic, you've got a cured patient, not a managed patient. As far as the statin drugs, I reserve statins for people who are real sick. I don't remember from your history that this man had had a heart attack, stroke, heart surgery, which would be some of the criteria I would use for treating the person with a statin drug in addition to a strict healthy diet. But if this was primary prevention, the statin drugs, plain and simple, don't work. So why bother? Let's see, what are the metformin? I don't use metformin. I think this is the last drug that doctors still prescribe because they think it does least harm. Not any good, but least harm. You know, I'm familiar with the arguments about how metformin may. I'll tell you what I remember is that it decreases the risk of developing by photograph retinopathy. So, you know, I wouldn't bother with that either. And anyway, I have a different kind of dealing with people. I don't manage patients. I figure out what's making them sick. What's making this man sick is the rich Western diet. I change them to a diet that is about 90% sugar. Okay, it's 90% starch, rice, corn, potatoes, et cetera, with fruits and vegetables, very low in fat. And the response is, and our data shows it, the average weight loss is 3.1 pounds eating as much as they want in 7 days. The average drop in cholesterol in 7 days is 22 milligrams per deciliter. We're able to get nearly 90% of patients to reduce or stop their diabetic and blood pressure pills in 7 days. Yeah, I don't know, what else did I not cover? So, you know, that's the way I would approach the problem. I know that's a little scary, particularly if you don't have the kind of experience that I've had. You know, I've done this a lot for many years, but quite often, in fact, I enjoy Dr. Lim is taking over as medical director in my program, and he's just getting to the point where he'll stop 120, 140 units of insulin a day, first day when they come to the program, because they're type 2 diabetic, which means they don't need insulin. That means they don't need diabetic pills. It means they're 100% curable. So I suppose that would be a pretty radical recommendation. I'd be happy to hear your comments. Oh, as far as the Xarelto or the similar drug that patient was on, I don't recall that being used for flutter. I recall it being used for atrial fibrillation, but not for flutter. You can correct me if I'm wrong.
Yeah, I think it was and again, he was established, you know, well before I met him. I think it was like a fib flutter kind of thing, and he did go through a cardioversion. So I think it was just 1 month that he was on the Xarelto.
Well, what I would do with this particular situation is I would use the CHAD score and decide whether or not he would benefit from blood thinning approaches, Coumadin, Xarelto, et cetera. And the CHAD score tells us that healthy people, relatively healthy people, should not be taking these drugs because their risk of complications are so low and the benefits are so few and the risks are substantial, of course. So that's the way I would deal with it. If he had a high CHAD score, I would probably, I'd probably use the new modern blood thinning drugs like Xarelto. I think I've passed the use of Coumadin. You know, in my years of practice, of course, that's all we used, but there are better drugs these days.
Dr. McDougall, now that you're doing things virtually, do you have the same confidence about taking people off of their medications?
Absolutely. And again, Dr. Lim, who's trained with me for over 5 years, and it's taken him a while, of course, it would anybody, to get the confidence, but yes. But I'm in a situation where every morning the person is seen by one of our support specialists. And so we find out what their blood sugar is, their blood pressure, whether they've had any hypoglycemic reactions, what they're going to eat that day, other problems that we've had. So I do keep close contact with people, even in a telemedicine type situation, maybe even more intense contact with them, because our staff gets to they have the luxury of more time with each individual. So again, you're talking about therapeutic approaches that everybody should be doing. We should not be treating type 2 diabetics aggressively with 4 shots of insulin a day, 4 pills a day. That's what those studies that were published in the New England Journal of Medicine showed. And if we're gonna practice based on science, then we got to do what science says, not fear of criticism from our colleagues, or worse yet, a lawsuit. We got to follow the science.
Sure. Dr. Graff, do you have any comments?
Yeah, my feeling would be that doing this without having stopping all of his diabetic medications and all of the other medications without being in a program where you're being followed every day would be really nerve-wracking and potentially dangerous. So I didn't feel comfortable kind of just stopping everything without giving him the support that he needs. So I might have referred him to kind of said, look, this has really worked well for you so far, but if you wanted to really get aggressive with this, there are online intensive programs now available. We could send you to that, but I wouldn't have done it kind of just stopped everything immediately without having that kind of support in place.
As I mentioned, we follow these people up all day long.
Yeah.
Well, they're being watched very carefully by myself, Dr. Lim, our nurses in our program, and so on. So it's not a matter of casually just sending them out.
Agreed. But if this were my patient seeing them, and if I were seeing this patient in my practice, if he didn't sign up for an intensive program where they were watching every day, I wouldn't be comfortable doing it. So I would talk to him about that choice. Like, look how much progress you've gotten. You could get off all of this. Why don't you think about doing an intensive program? Or else I would continue more slowly to wean him off.
All right, let me ask you, what would be the consequences if he's a type 2 diabetic of stopping all his diabetic medication? What would be the consequence? Okay, since there would be none, except his sugar might go up a bit. What would be the consequence of leaving the person on insulin or other diabetic pills? It could be very serious. You could have a situation where the patient becomes hypoglycemic, gets in an accident, gets picked up on the street with a DUI. I think it's pretty darn risky to leave people on drugs, particularly after you've changed their diet.
Interesting. Dr.
This
Scheuer?
gentleman's neuropathy was highly correlated to how high his sugars were, and I would be worried that we get into that we might prompt him to have another downward spiral, where if his sugars went up and his neuropathy got bad and he stopped walking, that we'd end up kind of in the same. A lot of his care, a lot of his health got better because he was walking regularly, as well as the diet changes. So I wouldn't feel comfortable doing it that abruptly, but I would continue to work to decrease over time. His hemoglobin A1C and his fasting sugars were still right around 200, right, at this point.
Yes.
Yeah.
But what would happen is with the change in diet, the insulin that he makes would be working much more efficiently, because sugar increases insulin sensitivity and it works better, and fats and oils cause insulin resistance. So you're putting the person in a situation where you would expect that they get better blood sugars. There are 2 references I'll give you on diabetic retinopathy. One is Neil Bernard. He just published a paper showing that diabetic neuropathy is improved with the change in diet that we're talking about. The other is from Weimar Institute, which is somewhere around Sacramento, California. And they report there, I'll try and give you the numbers accurately, out of 24 people who had diabetic neuropathy, not retinopathy, but neuropathy. Out of 24 people, they had 17 people who got rid of their diabetic neuropathy, and they maintained freedom from pain for 4 years. So I would approach the diabetic neuropathy different than giving drugs to cause symptoms. I would approach it from the point of view of relieving the cause of the problem. This patient is sick because he's eating the rich Western diet. This is a diet of kings and queens and aristocrats. It's been making people sick for 5,000 years. You get them off that diet, get them back on a traditional diet of human beings, which is a starch-based diet. You know, like the Aztecs and Mayans were known as the people of the corn. The people in Asia, 90% of the diet of the Asian before 1980, 90% of the diet was white rice. They didn't have type 2 diabetes and they had no obesity. You know, in the general population, there were a few exceptions. Now, at least as of 2013, 12% of the Chinese population is frankly diabetic and half are pre-diabetic. Again, they have adopted the diet of kings and queens, which is the diet of Americans. And, you know, my goal is a little bit different than I was taught. And I'm certainly happy I don't have to manage disease.
Sure. Dr. McDougall, I think you're, a lot of people here think you have a tremendous amount of courage. Well, we know you have tremendous courage back, especially when you started. So let's just hear it from Dr. Scheuer.
Hi,
Yeah.
thank you so much. So I think there's a couple of really good points here. As Dr. McDougall said, I get him on a very low-fat diet and a correct lifestyle medicine with, you know, the diet changes, the exercise and all that. But I also agree that I have some concerns about somebody who's outpatient and not following up and has a history of non-compliance. So I agree with Dr. Graff. What I would do personally, I would probably do some testing. One, do a C-peptide to see if he is type 2 or type 1.5, because that would adjust what I do. I would consider putting him on a continuous glucose monitor, so we avoid any hypoglycemia and things like that, and where they can actually really see how their diet, how their exercise, and how adjusting their meds affects their sugars. I would be very concerned about taking him completely off the Crestor immediately because of his triglycerides, not necessarily the other cholesterol, but the triglycerides, because he was, you know, over 500 for a long time, and that just increases your risk of pancreatitis, which wouldn't help. So those are some things that I would take into consideration. I'd want to know if he's on alcohol. Why is his triglyceride so high? Let's make sure he's not taking any alcohol without us knowing about it, because I don't remember that being seen or talked about. So yeah, I might want to check some other things, you know, how's his kidney function, what's, you know, some other things like that, but high fiber and low fat, and work on, I love the Mastering Diabetes program. I think that was a great suggestion because there's a lot of really good support in that. And there's a lot of education to teach you about what truly causes diabetes, like the standard American diet. So those are some of the things I would take into consideration.
Yeah, I think those are all, you know, reasonable steps to monitor the patient more carefully. Remember, I don't do an outpatient practice, and you're in a situation where you're right. You don't have the opportunity to observe the patient all the time, but I think you have to take an assumption when you start taking care of a patient, whether it's an inpatient situation or outpatient. You have to take the assumption that the patient is going to follow your advice. To deal with patients otherwise, you don't stand a chance if you don't trust the patient. So, and I realize they're not trustworthy. You know, I'm not saying that, but starting out by dealing with the patient with the attitude that they're going to cheat, that they're not going to be a good patient, I don't think is a good way to establish a doctor-patient relationship.
One comment I have, and Dr. McDougall is a little bit different in having his own clinic and closely monitor, and those of us who are sort of in a general primary care with quality measures. And what would it look like to those of us who are doing care gap and quality measures if we still have an A1C that's elevated, clearly not in the acceptable range, lipids that are still elevated, and we discontinue all these medications, right? We run the risk of, when those quality measures come out and care gaps come out, that who is this crazy Dr. Sundermann who has still got an A1C of above 8 and lipids that are still elevated, and she just discontinued the medications. Like, so maybe, Bob, if you want to speak to that, like, how do we navigate that too, that we're not dinged as physicians when we're taking a more radical approach?
Yeah, it's true. The system is built around the medical paradigm of diagnose, treat, and measure quality scores based on how well you're doing that, rather than reversal, value, improvement, overall health. And so that needs to change too. I think in terms of, Dr. McDougall mentioned that you've got frustrated doctors here, and I agree. I kind of practice both concurrently. For the patients who will follow it, boy, all in lifestyle medicine, and the others are frustrating. It's true, John. It's like hard to do. And you can see this in this pattern too, where this patient kept switching PCP to PCP to PCP. His doctors didn't have root cause treatment for this in their tool bag. And so they weren't really helping him, and they was looking for somebody who would. Fortunately, he found you, Melissa. But what we've got here is a situation where, as Dr. McDougall mentioned, these aren't really diseases at all. Diabetes, hyperlipidemia, hypertension, obesity, these are natural consequences of the standard American diet. And just like smoking would cause cough and eventually emphysema, standard American diet causes metabolic imbalance, insulin resistance, chronic inflammation, microbiome dysbiosis that leads to these conditions that once you undo it, once you stop smoking, the cough better. Once you undo the diet, the body goes into healing mode. So our role as lifestyle medicine docs is to inspire intrinsic motivation so that that person understands that, oh, it's not just giving up donuts and cakes, it's intramyocelial lipid, it's fat inside the liver and muscle cells that's causing insulin resistance. And by cutting out that, especially saturated fat in the form of chicken and cheese as two of the highest ones, but also fish and eggs and oils, you can unload that preferentially and very quickly turn around that insulin resistance and many of the consequences. John mentioned reversal diabetic neuropathy. Also, diabetic retinopathy is reversible in its earlier stages. You can reverse the atherosclerotic plaques that come as a result of the insulin. So we work to bring people to, again, that sense that even without close monitoring, like you've got your residential program, they bring there. And the tools for that are things like Jumpstart, things like the resources, documentaries, tools that Melissa mentioned. So sorry, I could keep going, but we're running short on time and I want to hear the rest of this story. What happens, Melissa?
Okay.
But Dr. Graff wanted to just make one point.
Yeah.
Well, I just wanted to say that it was such a huge missed opportunity at that first appointment in 2014 when he was really irritable. Like, why was he irritable? What was his why? Why does he want to change? Why is he feeling overwhelmed? Yeah. And, if you can clue in, I mean, one of the big things in lifestyle medicine is that, it's fingers, forks, feet, sleep, stress, love. What do you love enough that you're willing to change for? And to really approach it from that standpoint. And it's mentioned in that very first thing, he's got a dog. Don't tell him to go to the gym. Tell him to walk his dog every day for 30 minutes. Make it a positive thing. They're like all of these missed opportunities that kind of happened along the way with him that you could have gotten him probably on board way back in 2014. If we had used the right levers, but we were so focused on the disease that you kind of missed how you can get this guy to go along with you. And if you can't get somebody to kind of make it their journey rather than you telling them what to do, then you're not going to get anywhere. You're going to get exactly what you got with this guy, which is that he goes in and out of care. And, you throw a bunch of meds at him, you give him an impossible diet. I love the diet where it's like no carbs, but no fat and there's nothing left. All you've got is protein left. If you're doing no carbs and low fat, like what are you going to give the guy to eat? So no wonder why he doesn't follow it, right? It's just kind of impossible. So
yeah, no, thank you, Kerry. Totally agree. Thank you. All right, so
and Melissa, could I make one more point? Which was just that there was a bigger focus kind of towards the beginning on smoking cessation. Yeah. And I don't know if anybody else has found this or not, but I usually address smoking as the last thing because people are so paranoid that they're going to gain weight and they're going to not eat well when they stop smoking. And honestly, once people start eating better and feeling better and start walking, then what I find anyway, is that a whole lot of them just stop smoking on their own because they don't want to be short of breath while they're exercising. And it just kind of like comes naturally.
Mhm.
So
Yeah.
I put that on kind of like the bottom of my to-do list. And it's actually really positive with patients when you say, I know, you shouldn't be smoking, but like, we're going to put that on the back burner for now. And patients are like, wow, you're going to put this on the back burner. You're not going to like, that's like, they kind of like, it helps get them on board because you're not making them change one of the hardest things for them to do right at the beginning.
Yeah.
Very
Okay.
interesting point.
Thank
Yeah.
you. That's
Anybody else have
yeah.
that? Anybody else have that experience where people will stop smoking as part of the journey, kind of like on their own if you don't push it, but if you push it at the beginning, like
Well,
game
what's
over, you don't
what's
get anywhere?
interesting too, Kerry, is I mean, think about how palates change, right? When we get people to switch to a whole food plant-based, they're like, oh my God, I hated kale and Brussels sprouts, and now I absolutely love it. Or I can't even have anything with salt on it because my palate is so hypersensitive. I think it can go along with smoking too. Like all of a sudden, like senses are so heightened that tobacco smells like crap, right? So I think we heighten all of our senses when we transition to a healthier lifestyle. So that could be having some play to it too.
Wow.
All right, so let me get this screen to advance. Okay, so he comes back to see me on October 22nd. He was super psyched by his labs that came back, and he really is motivated. He wants to lower his medication. He's pretty much been following a plant-based diet for the last 3 weeks. He's lost 5 pounds since his last visit. He states, I feel like I'm getting my life back. I can't believe how fast the changes are and improvements are happening. He actually watched Forks Over Knives, and he was researching YouTube videos on plant-based eating. He states that neuropathy in his feet has improved. And his sleeping was improved too. He wasn't snoring as much. He's checking his blood sugars, and they're running around 130s, and his BMI is down to 28.9, which is the lowest it's been since 2014. This was actually a video visit with me, and he was so cute. He said, I wish I was going to be seeing you in the office because I was going to bring you a bouquet of flowers. Like, I don't know what you're doing, but this is working. So of course I wasn't doing anything other than empowering my patient and believing in him.
You know,
So
he can still send you flowers.
that's true. That's true. He knows my office is. So, you know, again, I don't know if there's a perfect science to how deep prescribe. That's why that's the title, like what's solving the mystery. So I elected to what some of you had mentioned, and I decreased his Lantus down to 20 units per day. And then I really just want to get him off this Lyrica. Like he's going to get better just with his improved glucose control. So I didn't want to just take him off right, just cold turkey. I was worried about just having some withdrawal. So we decreased that by 100 milligrams TID to 50 milligrams TID. We started educating him about the gut microbiome, really with that connection that Bob Breakey had mentioned of dysbiosis and how that's tied to his, inflammation, insulin resistance. So we talked about the Fiber Fueled book by Dr. Will Bolsiewicz, which is a great for lay people as well as medical professionals. We counseled on how to best continue his whole food plant-based SOS-free diet. I gave him my whole food plant-based grocery shopping list. I gave him the whole list of documentaries that, as Dr. Breakey mentioned, are just really powerful tools. I say I'm one doctor is going to tell you to go home and watch TV. So go home and watch these documentaries. And then we talked about what forms of exercise. And Kerry, I told Dr. Graff, I totally agree with. He's got a dog, right? And go out and walk that dog for 20 to 30 minutes per day. We just want movement. I rephrase exercise to movement and just say, you just got to move your body. And we did order some repeat labs. So I get his labs back. This was just last week. His A1C had gone from, again, 6 months ago, 11 down to 8.1. And I had lowered his Lantus at this time, and he continues to trend down. Not a huge change, but in the right direction with coming down on his Lantus. So that was encouraging. I got his lipids panel back, and I was a little bit perplexed at this. Now, he's lower than he was 6 months ago, but his total cholesterol went up over the last month from 157 to 217. HDL came up just a little bit, but triglycerides had come down all the way to 248, had gone back up to 400, and LDL had gone up as well, 61 to 86. So I was a little bit, because I didn't do anything to his statin, so I was kind of scratching my head what was going on. Microalbumin was slightly increased at 48. Still scratching kind of my head, not a big change. So, you know, the current medications, he's taking Lantus 20 units that had come down. His metformin is still taking 1,000 BID. Lyrica, we're down to 50 milligrams BID. Crestor is the same, and he's still on his lisinopril at 40. So again, actually, let me forward one slide because this kind of makes sense. I, you know, sort of was a little bit confused by his labs. And so I, you know, sent him my chart message. Are you still doing plant-based? Are you taking your statin? And this is kind of how this patient is. I think that he wants to be compliant and he really is feeling better, but yet he falls into old habits. So he said he's doing good with the whole food and veg diet, with very and small and quantity deviations. So considering the meds, I ran out of the metformin and the statin weeks ago. And based on the great numbers from last blood work, he wanted to wait for these next labs to see if he needed to keep taking them. So he was also running low on lisinopril. So that kind of explains why those cholesterol numbers went up. I mean, they're not crazy high, but even though he ran out of the metformin and we went down in the Lantus, his A1C came down a little bit. And then considering the Lyrica, it's not making any difference. So he decided he's just going to stop taking it. So now he wants me to order more labs, which I have done. So I guess going back, this is going to be the last poll. So I want you guys to kind of like guide me what you think we should do. You know, we're seeing those are the change in numbers, and he's basically had stopped taking on his own, the metformin and the statin, and we're down to 20 units of Lantus, and he is taking himself off the Lyrica. So you can ignore number 4, I guess, because he's decided I didn't know that he had taken himself off the Lyrica. I just got that by chart message today.
While everyone's thinking about that, I just want to jump in here. We've actually gone a little overtime already, but we're not going to stop this great webinar. But for those of you who do have to leave, that's okay. You'll still get a CME credit. You'll be receiving an email in the next hour or so with instructions on how to fill out the survey to get your certificate. But I think we're going to go till 8:45, so another 15 minutes, because we're doing, I think this is getting pretty interesting and I don't want to cut it off. So. And it looks like we're not losing anybody, so I think we've got them on the edge of their seats. This is where we want them.
Number 6, all of the above.
Yeah.
All right. Oh, we did get one of those. Okay. All right.
Okay, so it looks like most of you think I should continue to keep going down on Lantus. And then some people say stop metformin, and then wean off Lyrica. Yep, we're doing that. He decided to do that on his own. Didn't even need my direction for that. And then also just a couple people saying to lower lisinopril and lower the Crestor. So maybe the panel wants to, you know, give their input.
Well, I know what Dr. McDougall would do. He put them in a residential place and take them off of everything. So we're going to get to you, Dr. McDougall, but let's hear what Dr. Scheuer would do.
I definitely agree. I would continue to get him off of his Lantus, make sure he's off of his Lyrica. I think I would go for the metformin last. In terms of his triglycerides, I've actually seen quite a few people go up on their triglycerides a little bit when they start to lose weight, when they start to do a plant-based diet. And so be a little careful on that one. Make sure he's not, you know, having that his coffee, if he's having any coffee, that it's not unfiltered, because that'll increase his triglycerides, things like that. So, you know, preferably get him off of that, but, and continue the support on making sure he's staying plant-based and watching the videos that you recommended, the books that you recommended. The more positive input we get in, the better it is. Walking his dog, it's good for his dog and him. So I think you're on the right track. And if you can keep him feeling happier and healthier, he will continue to do this.
All right,
Thanks.
I think so. Dr. McDougall, we have a question about the triglycerides going up on a plant-based diet. Could you just comment on that quickly, please?
They do. Simple sugars, for example, will cause the triglycerides to go up. I've even found that fruit and fruit juice will cause triglycerides to go up. And of course, alcohol will. I got a big kick out of you saying filtered coffee or unfiltered coffee, because I had, it's been a long time since I remember the difference in methods used. Using the coffee filtered through a paper filter, you remove a couple of cholesterol raising substances when you use a paper filter. So I appreciated that very much. Exercise, of course, lowers triglycerides. Just in time, they come down. In our study of 1,703 people, we found that triglycerides did not change overall, which means, for most people, or for some people, they went down tremendously. For most people, they either stayed the same or went up a little bit when we changed them to a starch-based diet. So anyway, I wouldn't worry very much about the triglycerides. I understand the pancreatitis issue, but they generally come down. And I think I'd use clofibrate. Isn't that what's used? Or they used to be using niacin. I don't recall Crestor being a very good drug for triglycerides. It's good for cholesterol, but there are more specific triglyceride lowering drugs. If that was your aim.
Yeah. I would say increases omega-3s with, flax seeds, and make sure there's gemfibrozole, there's fenofibrate, things like that, but they also have their side effects. So
Terrible.
it's nice not to add meds.
That's why I take them off all the drugs. Then I don't have to fight over the side effects and the costs and so on.
Sure. So Dr. Sundermann, Dr. Graff, you had want to make a point?
Yeah, I guess my feeling is the most important thing at this point is to build this guy's support group, right? Because right now he's doing all this stuff online, but he's doing it, as far as I know, all by himself. He doesn't have anybody doing this with him. And it's probably not going to be sustainable if he doesn't get a really strong support group and get linked into that. So I would figure out how to link him into real people that are going to give him ongoing support, that are going to help him. I'd also think about asking if he wanted to do 2 weeks of the very best that he absolutely could do, and then watch those sugars during that time. He might have already done that with the 2-week jumpstart, since he already took that.
Yeah, so I referred him. Yeah, I referred him to Jumpstart. I don't think he signed up, but that's a great idea. Just now that he's seen how he can be in control of his numbers, that objective
it would
data.
be super motivating, right? So if you could say, I'm going to take you off of absolutely everything. I need you to give me 2 weeks. Well, this is what you would offer, right? You'd see if he goes for it. He may not. But would you want to try coming off of everything and doing it absolutely as perfectly as you can for the next 2 weeks, and then see me again in 2 weeks, and we'll see what your blood pressures are running, what all your sugars are doing. Hemoglobin A1C won't matter, but give me some fasting sugars and get me your 1 to 2 hour postprandials. And let's take a look at everything and see what you really still do need and what you don't. I would leave him on the lisinopril though, because of his microalbumin, because even with his better control, his microalbumin was high. So I probably wouldn't take him off that.
Okay.
And there's a great group called the Plant-Based Nutrition Support Group, which is a good one, but I agree that the Jumpstart would be the best, really phenomenal.
Yeah, that is good. pbnsg.org has great services for people. Started here in Southeast Michigan and is now is national. Ted, Melissa, the thing I see a teachable point in this case related to deprescribing is, Melissa, as you mentioned in the beginning, we're lifestyle medicine docs primarily, but we do use meds where necessary. But from the early stages, whether either I first meet a patient or I start them on a med because it's a stopgap in critical timing, I say to them, our goal is to get you off of these meds or to stop this as soon as possible. This is a stopgap measure, or these are propping you up now. And as we get rid of the root cause, you will need to get rid of them, or you may get hypotensive and pass out. Your blood sugar may go too low. You'll get extra problems on top of the already large number of side effects that are possible from these, because there's such an emphasis on the numbers. And if someone has an A1C of 8.1 and they go down to 6.8 with medicines, they think, hooray, I'm a success. If they are 8.1 and they go down to 7, but they're off their medicines now, that's even more of a success. We have to set the stage early on that de-prescribing is part of our goal, because these meds are just Band-Aids, or just treating symptoms rather than getting to the cause. So help this guy to see early on that as he gets rid of meds, that's great progress and equal or better than improving numbers.
It's a great point. Dr. Sundermann, is there more of your case that you want to show us?
Not really. We saw this message, so he is booked to see me, and we'll just have to see. And there's what we prescribe, right? So that's our pill box.
Yeah, beautiful.
That'll raise his triglycerides.
Are those yum yums? The
I have no
little thing at the
idea.
bottom?
That's a stock photo I found. So but they do look really cool, don't they?
That's
Yeah.
great. Yeah. Well, I want to extend a hearty thanks to our distinguished panelists, especially Dr. McDougall for joining us tonight, and for Dr. Sundermann, Dr. Scheuer, Dr. Breakey, Dr. Graff, and everybody out in the audience. We're so glad you were able to join us. If you would like to get credit for tonight's lifestyle medicine grand rounds, just fill out the survey that you'll be receiving a link to in the next hour or so. And this is accredited by the Rochester Academy of Medicine. And you will be able to print out a certificate, or just copy get the PDF. You can send it into your staff to keep track of that. That's what I do. So I don't, does anybody have any final remarks? Bob, Frankie, am I supposed to make any announcements? Oh, I do have the announcement. So we're doing this again next month. Dr. Neil Barnard will be our guest panelist, and that will be December 14th. And I can't remember what day of the week that is, but I think it's probably a Tuesday. Yep, Tuesday, December 14th at 7:30, same time. Yeah, another interesting case. And the case will be presented by our Dr. Scheuer. So yeah, very excited about that. And yeah, Dr. McDougall, you have any final words for us?
I just want to thank you all for inviting me and let me express my very strong opinions. I've been at this for a long time, and I practice diet therapy. My goal is to get people off of drugs and to get them as well as possible. And I want to emphasize what many of you mentioned, and that is that compliance is extremely important, and support is extremely important. And that's why we have found such success, not only in our residential programs that we used to run before the fires, but in our telemedicine program, because we start out in the morning. We have group meetings with these people. We have support specialists that follow them all day long. And again, Dr. Lim and I are available all day long to help people. And that's necessary. Not necessarily because you want to keep them off the medications, but you really want to get them through this tough dietary change. This is not easy.
Well, Dr. McDougall, thank you for the pioneer work you've done. And just also thank you on behalf of our family, since we have 3 vegan children who are now 29, 31, and 34, and have been on this path now for doing really, really well. And my wife basically became an expert by reading your books. So that's how we had one of the reasons we were so confident that even though we were performing an experiment on our children, it would probably come out okay. And it did come out. So yeah, there we go. There are the books. So, right. So thank you, everybody in the audience, for joining us, and hopefully we'll see you next month. Good night, everybody.
All right. Thanks, Ted.
You're welcome.
Thank you.
Yeah, bye-bye.
Melissa, great to see you.
Yeah, good to see you too, Carrie.
Yeah, fun.
Great job, Melissa.
Take care, everybody. Thank you.
Great
Thanks.
job.
Good to meet you,
Good
Kim.
night.
Give me a sec.
Bye.